Hello, good afternoon, and welcome to our today's session of the SACME Virtual Journal Club. I would like to welcome all of you on behalf of SACME and our editorial board to this exciting session. I'm really thrilled to be able to welcome back Professor Alan Knox from University of Wisconsin. The topic today is Inquiry, Terms, Learning, Performance, the Mutually Beneficial Exchange. Many of you know Alan's work and are familiar with a lifelong and very accomplished career that he had as a teacher, administrator, professor, and scholar, certainly editor and the leader in the field of continuing professional development in the health professions. I would like to mention that this is our 10th session. We are in our 3rd year of the Journal Club. And at this point, I would just like to remind you that, as usual, our mighty facilitator, Dr. Curtis Olson, our editor-in-chief of the Journal of Continuing Education in the Health Professions, will be moderating this session. So with that, I turn you over to Alan and to Kurt. Thank you.
Thank you very much, Mila. Just a few quick technical items before we get going. Just a reminder to leave your phone unmuted. I can control muting from where I sit. If you have a comment or a question that you would like to offer, please just use the control panel to raise your hand, and then I will call on people in order. And beyond that, if you also have the option of using the chat feature to ask a question, and I can relay it to our presenter in that fashion. We mentioned that there was a Compendium website in the introductory materials that Dr. Knox prepared for us, and then we neglected to include the URL. You can find the URL for that website in the chat section on your control panel. It will also be added to the SACME website where the rest of the information about this session lives, and so you can find it there as well. So with that, I will switch my microphone to mute and welcome Dr. Alan Knox.
Thank you very much. I have a feeling that I've been amply introduced between Philip and Kurt, and so let me proceed. I am looking forward to this next hour together and a spirited discussion, given the talents of the Virtual Journal Club participants who are on the line right now, and the mission of SACME, and with Congress coming up in about a month and seeing some of you there, the topic that I'm suggesting that has the somewhat strange title of Inquiry, Terms, Learning, and Performance, Mutually Beneficial Exchanges, is dealing, as most of you, I assume, have read through that brief material that I sent out beforehand, with relationships between people in largely practitioner roles in the field and people who are experienced and interested in the scholarly contributions from research and evaluation. Throughout the entire history of SACME and the Journal of Continuing Education in the Health Professions, there have been a number of key people who have straddled both the practitioner and the scholar roles, and an increasing number of people from originally from one side or the other of that equation who are finding that those sorts of exchanges are indeed mutually beneficial. And so what I'd like to do, and I think the readings and the discussion questions focus on as well, is the ways in which we can take advantage of that partnership, those connections, and the project in the Journal of Continuing Education in the Health Professions, my little editorial at the beginning of that, having to do with reflections on terminology in continuing education of health professionals addresses that question as well. And several of the other items that I refer to in my preliminary comment refer to other resources that are available that promote that sort of exchange and collaboration. And so I would welcome any comments or questions or clarification that anyone would like to mention right now, and proceed to the 4 discussion questions and use our discussion of all or most or all of those questions as a way of dealing with some of the details that I would add later on. So, floor is open for any questions or comments that anybody would like to make at the outset before we receive. And I have been graced with a listing as of yesterday of the people who are scheduled to be here, and I am appreciative that so many people that I know and know a good deal about are on the line. So I have no doubt that our discussion will indeed be spirited. So, floor is open.
Okay, so I am watching the list to see for hands raising. So because everybody is reflecting on what they've read and your introductory comments, Ellen. So perhaps you'd like to speak to the first discussion question, Alan, and say a little bit about why you wanted to start with that question and what you were hoping to elicit in terms of engagement from our audience.
At each of your institutions, and the University of Wisconsin-Madison as well, there are connections between people who are in practitioner roles in a variety of ways and people who are concerned with research, evaluation, scholarship, and various other ways, who are trying to help in conducting effective continuing professional learning activities of various sorts. And so the question that I've raised at the outset is, how important is that? As you think about your own institution, are there no or a few or many people that you are working with in your continuing medical education quality improvement activities who are in roles that are not mainly clinical medical practice and focusing on updates and information and making arrangements for that to occur, but people who are contributing in other ways to that effort, as a way of illustrating the extent to which there already is or is not some mutually beneficial exchange occurring between people who are in clinical staff supportive roles making arrangements for continuing medical education, and people with some experience and interest and potential contributions related to what I've labeled the scholar role.
Mm-hmm. Well, your question about what can be done or how important is it to strengthen connections between scholarship and practice suggests that there will have been a history of that conversation between what's available in the scholarly literature, between what we do as practitioners, between researchers as individuals and program planners or faculty or learners. So I'm wondering, perhaps one place to start is to ask our listeners what the nature of that conversation, so to speak, has been to this point. In what ways have you made use of the scholarly resources that are available to you? In what ways have you, as a scholar, collaborated, worked with the practitioners in your setting or elsewhere? See, I see Don Moore has his hand up. Hello, Don.
Thanks, Kurt. I think that my connection is with course directors. We meet with course directors on a regular basis, and of course most of them are unfamiliar with the field of continuing education for the health professions. And we are very concerned about helping them understand the transition that's going on between what the expectations are for CME, CPD. And of course, those expectations are moving more towards improvement rather than update kinds of approaches to continuing education. Most of the course directors have been brought up in that environment of update kinds of activities, and are not to say resistant, but perhaps reluctant to change that format because they think that that's what works. So we take the opportunity when meeting with them to explain what the new approach is, and we try not to use educational language, if you will, as a way of doing that. And we have changed our forms, that is our application for credit, to be much more people-friendly, if I can use that term, as a way of guiding them through the process of what they're trying to do and what they're trying to accomplish, and not using terms like needs assessment or learning objectives or instructional design, but to try and talk to them in their own language as a way of helping them understand what it is we're trying to convince them, persuade them to do in terms of changing their approach. It has been less successful than we had hoped. It's not easy to change habits that have been ingrained for many years, and we found that the course directors that are, let me say, younger, seem to be more in tune with what we're trying to accomplish in terms of changing the focus of our activities, but still are a bit nervous about proceeding because of concerns about the participants in their activities. So we're trying to make that connection. I think we have a little bit of success, at least in terms of recognition that this is an important new change. And we believe our next step is to begin to help them understand how to design their activities so that they can reach these more advanced goals.
Great. Thanks, Don. Ed, your comments address the second and third of the discussion questions that I had sent out beforehand, and I wonder what other people who are on the line right now would characterize their own CME activity, relationship with course directors or other people that you're trying to help as partners in the process of continuing medical education. How typical is what Don described, and how difficult has it been in those instances to use terminology that fits both the experience and the familiarity from the course directors or other staff or faculty you're working with, but also communicate some of the ideas about active learning, ongoing evaluation or assessment, trying to improve interprofessional education activities where you have people from multiple specialties who are together, and some sort of generic terminology as the JSEP issue and editorial dealt with. So what's been the experience of other people, either similar to what Don has just described or contrasting in some way?
Okay, I see that John Parvasing has his hand up. One moment here. Welcome, John. Hello.
Thank you, Kurt and Alan. I can only speak from the past because I'm retired, and I would echo exactly what Don has just said. That is a role which I think I played quite often in my CME office as a physician as well as an educator, is communicating in another sense with the audience, if you want to call it that, and that is the grassroots physicians out there, especially when we are trying to develop a research project and you're looking for volunteers, and especially if it's a research project that involves the physicians doing some homework and keeping records for you and keeping a diary and things like that. You need in a CME office a handful of clinicians who are known to the other physicians out in the region, and because of their relationship with them, you're able to recruit them for research purposes. So that's just yet another role, but I would certainly echo Don's role that he mentioned.
Great. And for the people who were involved in the terminology project that was reported in JSEP, they were struggling with the same sort of question in terms of what they set out to do over several years' time to try to come up with clear, useful definitions, not of the clinical problems that research or clinical practice would be dealing with, but to deal with the process of teaching and learning. And there is a terminology that exists in various aspects of the broad educational field that has been referred to in terms of needs assessment or other terms that may be unfamiliar to the people who are in as course directors or other roles that John has referred to. So I'd like to focus for a little bit on the process. The process not of disseminating updates of new information about health problems and solutions and procedures and so on, but the process of teaching and learning. And whether that teaching is one-on-one mentoring or consultation of a physician and a patient in John's office, or groups of people who are, as course directors, trying to figure out better ways to make a difference when they make arrangements for some of their colleagues or other people in the professional field to help in planning and conducting various types of grand rounds or other activities that are more likely than most to make a difference. One of the articles that was in JSEP a decade ago that Dave Davis and colleagues had helped to establish tried to map something of the environment within which people who are doing CME are working. Some of the influences on that, and part of it has to do with understanding the patients and their experience and the terminology that they understand and so on. Part of it has to do with the practitioners who are helping to plan and conduct continuing medical education, quality improvement activities, and the like. But there are other aspects of effective performance that has to do with some of the evidence that some ways of trying to promote effective learning and improve performance are more effective than others. And Dave and his colleagues for a generation now, and he and Bob Fox and other people have tried to point out that just disseminating update type of information to people may make the presenter feel good, but it doesn't have very much an impact on the audience, on the people who ostensibly are going to be beneficiaries of a CME activity so that they can pass along what they are learning to their patients, to their colleagues, to their other people in related health professions, and so on. So if we focus then on that process, are there any instances that people on the line right now could refer to that either is a typical way of trying to plan and conduct CME activities that is not as effective as it might be, that both Don and John have referred to, or are there some ways of assisting the people who are involved in those activities to come to understand better, not just the terminology, but the practices? Are there some ways, using Don's example right now, where a new approach of guiding the process, minimizing terminology that seems to be getting in the way, but at the same time move beyond the sort of update notion and one that's more likely to improve the performance of people who are paying their money and spending their time in CME activities. And if the research that I referred to before is accurate, not doing anything that's very much better as a result of that. So focusing on the process of interacting with the people who are helping you to plan and conduct CME and quality improvement activities, if that's our focus, what are some examples, and I'll provide some as well, what are some examples that do work, that are more effective in that regard?
Mm-hmm. If I may interject here, Alan, I have comments from Ginny Jacobs that speak directly to what you're saying. She notes that she agrees completely with Don's comment about the need to avoid language that is foreign to our clinicians, or edu-speak, if you will, when we're trying to build bridges between research and practitioners. And she too is wondering if there are any strategies that have been particularly successful when you're attempting to connect experts in each of their respective fields, say around the issue of finding more effective ways beyond frank dissemination to educate practitioners.
Let me cite an example that several of you people on the line are very familiar with, but others may not. And that is, tomorrow afternoon in the same time slot, we'll be holding an educator workshop session, a series of monthly sessions that are aimed at people who are in a variety of departments and specialties and so on, having to do broadly with the health professions. Not just one specialty where there's a tendency to want to focus on their terminology and the content and how you can disseminate that content, convey that content to through PowerPoint or some other arrangement to people who want to know about it. And we've done a number of things over the last 6 months to prepare for that. We've talked with people who are in those roles, in staff and faculty development in various departments, and identified some of the topics that they care about. And the first of those topics tomorrow is focused on active learning and ways to use that our hour together in that workshop in February as a way of sharing some of the ways within one institution, in one medical school and related health professions and so on, helping professions certainly. What are some of the ways that are working for people? And using those examples and using the terminology that makes sense for them. And then a month from now, there'll be a 1-hour workshop session that's already been organized, and there's the brief prior readings and discussion questions and so on. We've already taped a little website commentary to encourage people to look at that material, to read it beforehand and so on. And the focus is on that one is practical, ongoing evaluation activities that can be used for improving planning and conducting professional learning sessions. And the one the following month, in April, is going to be focusing on interprofessional education. A book that just came out by Stylus Press, dated 2016, is entitled Improving Professional Learning. And each of these next three topics is dealing with part of one of the chapters in that book. But all the materials are in the public domain. We prepared them in such a way that there's no problem in terms of copyright or anything of the sort. It's just available for that purpose and can be recycled. It can be used at a later date here in Wisconsin, or it could be used elsewhere as well. Now, one of the features of what we're trying to do in that series of workshops is to build a learning community of the people who, for the most part, do this sort of thing, having to do with staff and faculty development, as volunteers. They're several steps removed from either scholar or practitioner in some instances, having to do with the process of teaching and learning. And they're looking for more effective ways to be able to do so. And so after these first 2 or 3 or 4 workshop sessions occur, we'll be involving them in the process of deciding what examples, what other people might join that workshop session for some period of time that would be helpful to them in what they're trying to do in their particular specialized department. So the combination of an inexpensive book that deals in more detail with that content, and it includes a bibliographic essay at the end providing more detail on further readings for people who want to go beyond the sort of practical parts of it and so on, and some repetition over time to see this is something that will need to develop, and where the people who are participating in that workshop series, as I say, become a learning community to some degree to provide a degree of continuity for doing so. And in Don and some of my interactions with him over the years was one source of inspiration for doing this sort of thing. Ron Cervero, who's now Associate Vice President of the University of Georgia in charge of faculty development there, is another person. I've talked to people recently from Kansas State and from University of Oklahoma and elsewhere, who are very interested in this because they have said to me in recent month or two, we are having problem with that same activity. And so one of the things that we built into that arrangement to illustrate ongoing evaluation and to illustrate use of technology is to have a number of people here within Wisconsin who are serving as sort of informal advisors, if you will, for what we're trying to do, in addition to the people who are participants in that workshop series. And we'll provide periodic progress reports to them regarding what's occurring, the number of people who show up, who they are, something, a summary of those sessions. Somebody who does ongoing evaluation in the medical school, this sort of activity, has agreed to serve as a sort of an ongoing informal evaluator of those activities as well. In addition to that, Ron and Don and 3 or 4 other people, including several people in statewide extension here, have said, I'd be interested in being connected in that some way. Could you provide those progress reports to me as well? And so that's the plan. And for anybody who's on the line right now who's interested in more detail of that, not only would I welcome your questions and comments about that relatively low-tech but sustainable way of trying to do that and to involve the participants in those workshop sessions in the planning and the conducting and the evaluating and the reporting on how it's going in their areas as well as a low-expense, high-yield strategy to use. Anybody who lets me know about that, I'd be glad to put you on the list, along with Laura and Ron Cervero and 4 or 5 other people.
Yep. We have a more general question in relation to what you're describing, Alan. This, again, comes from Ginny Jacobs. She says that the monthly sessions that you're describing sound interesting. I appreciate the fact that you are not setting them up as one and done. She also notes that this takes a concentrated effort. So what do you find that helps to incentivize faculty and staff to participate in that type of educational initiative? Is her question.
I'll give you a much better report in 3 months, to be sure, because that will provide a very good answer to your question. I've already mentioned 2 items. One is, over the last year or 2, we've been interacting with about 30 or 40 or something people on that total list that we just sent out regarding the first of those sessions. And so I'm starting with people who are already, in a sense, part of the choir. They're part of the effort to some degree. And secondly, I did brief phone interviews several months ago, 4 or 5 months ago, with about 12 or 15 people who were identified themselves, because, as well as being identified by Barb and Pat Cocotayo and so on, having to do with the Office of Continuing Professional Development and with the medical schools Faculty Development Advisory Committee. So these are people who have already been involved in a number of ways, and in those phone conversations with them, and I never refer to it as a needs assessment, I would just want to chat with them a little bit about this. In those conversations, they identified the topics and the methods and procedures that would be effective from their standpoint. Furthermore, we went through a somewhat elaborate process in the last month to ask people to identify those days and times that they regularly schedule clinic sessions in the morning or meetings in other parts of the week and so on that come on 1 or 2 days. And we picked Thursday afternoon between 2 and 3 as the time that was most likely to avoid those conflicts. So the combination of building on their commitment understanding and trying to do a little due diligence having to do with times and places that were accessible. Furthermore, some of the people in some departments said that part of their problem is the people they most like to help are not likely to get to the distance education facilities where Barb and I are right now to be able to participate. So we've set it up in such a way that we have access for people any place in the state of Wisconsin. So wherever they are working regularly or that particular day and time, that they have access to a telephone or a computer or something of the sort, they can participate in a live session, not a dead webinar, but a live session where they're interacting with other people who are there. And most recent information I have is about half of the people who are signed up for the first one tomorrow are doing so from a remote location. So you can use technology not to have a canned presentation that's one way again, but in a way that is interactive and building on the notion of a learning community. So those are a few tips, and quite frankly, the chapters, the 12 chapters in that book on improving professional learning are based on about 4 or 5 years of observing, interviewing, and in other ways studying and gaining examples and concepts that relate to those examples that work in the helping professions generally. And so that material from which we drew the prior readings for the sessions for the next 3 months, starting tomorrow, are already pretty practical and use examples that are familiar with people from a variety of fields. Again, we're trying to get away from the notion that we're just dealing with a specialty, which raises the temptation of people to go back to delivering the content of their medical or health specialty rather than focusing on improving the process of engagement and transfer to practice. And many of the people, quite frankly, who are helping out in important ways in continuing medical education end up by most of the time making arrangements and hoping that somehow or another the faculty members or the experts who are involved know enough about teaching and learning. And what happens is that they want to do CME in the same way that medical school was done to them, which was sort of one way and focusing on passing the exam or completing the degree or whatever the objective was, and not focusing very much, as John referred to it before, on the process of teaching and learning using technology that doesn't get, or terminology that doesn't get in the way. So, thank you for that comment. Other questions or comments about how to get engaged learning that makes a difference in actual practice? It make some of the people who've been concerned about research findings about CMA be interesting and lots of other things, but not making much of a difference in performance. So it made Dave Davis feel good to think that we were trying to do something to make a difference in actual performance, not just going through the motion.
Can I, this is Mila, if I thought about what you asking, Alan, and I wanted to share something from University of Pennsylvania, some recent work that we've done here that has really been strategically driven. And we looked at the interprofessional education as a catalyst to many of the focused areas we have these days in continuing ed in the health professions, be it the focus on quality, on outcomes, patient outcomes, on communication styles, improving effective communications. All of that sort of converged in a way in underpinning the interprofessional education that serves to, support the collaborative team-based care. So this was the language that resonated with the clinical departments. And this was something that we started from strategically from gaining the, if you look at the change management literature, looking at that both from anywhere, from meeting people where they are in the TTM model in Prochaska to leadership literature and the, the leading change ideas. So it was important for us to start with the leadership and get their buy-in, and we did. And so the high-level strategic committee was formed to drive this change. At the same time, we connected with the leaders in the nursing education department, and really over the period of 2 years prepared for what is going to be a change in accreditation for us, but decided to work primarily with our regularly scheduled series. And the reason for that was because we saw the opportunity there for all the reasons I stated. You know, this is where the teams are already made, clearly made, and it's less of a stretch and an effort to explain to folks the benefits of it. So over the 2-year period, I talked a lot, every opportunity I had, with clinical leaders, with course directors, with department heads, with our faculty at large, with coordinators. We did massive training. And my office was really involved hands-on extensively with nursing to coordinate the efforts, the planning documents, consolidate all that. And, you know, I'm really happy to report that you can imagine the kinds of response we've gotten. But overall, I think it has been much more positive than in many other areas. When you talk theory, educational theory to people, oftentimes for all the right reasons Dawn mentioned already, and many of you have, you know, it's difficult to talk that language. But this resonated well with most folks. And the net result is, I'm really happy to report that now, that we didn't only meet the expectations. 70%, over 70% of our overall RSS numbers came back this year as interprofessionally applied for interprofessional accreditation. And that meant truly planned interprofessionally, having planning committees that are interprofessional and so on, the objectives that meet those needs. And in addition to that, I thought that some of them would drop off, and they didn't. We have larger numbers than ever, so the overall number of series grew. So that is something that I wanted to bring up as a recent positive change from our experience.
Great, thanks, Mila. Let me mention briefly 3 examples beyond the one that I mentioned having to do with the workshop series here, and the offer to share that with people who would see that as a starting point to modify in their own situation. The first is that a number of years ago, I spent an afternoon at a conference that Barb was connected with, had to do with pediatrics and young children at risk in family situations that were difficult. And so it's not just pediatricians or social workers or people in law enforcement or in the public schools or in lots of other places. She and her colleagues put together a simulation. And over a 2-hour period of time, the people who were attending that day-long conference did other things in the morning, and in the afternoon, they went through that simulation. And the testimonials that some of those people provided at the very end of that and following up afterwards indicating how powerful that was. And so in that instance, Barb and her colleagues avoided some of the problems in the past of something that's dissemination, but they emphasized discovery using a simulation. It's a low-tech simulation. There are fancy simulations that can be used as well. So that's my first example. Secondly, for 2 years, I was working with PIRE, the Pacific Institute for Research and Evaluation, that got the contract to do the external evaluation for a Veterans Administration project trying to improve patient-oriented coordinated care in the VA system. Dave Rakel and some of his associates in the medical school here agreed to, over more than a 2-year period of time, and Julie Martinelli was working with them for that effort, who's in our Barb and my office right now. And they held 2.5-day workshops at locations where there were VA facilities, so that people who were could commute back and forth from where they lived to be able to participate in that. They were with other people from their own VA facility. In that 2.5-day period of time, the amount of progress that they made in terms of common understandings, understanding the importance of prevention as well as cure, the relationship between various roles and the coordination there and so on, was not only very substantial during that period of time, but as a part of that PIRE effort, we followed up a number of months after those workshops with people who had attended and did phone interviews, if you want to think of it that way, with a number of people at the location that was part of that several months earlier, that workshop, and asked them individually in that phone interview situation, what happened? What difference did it make? And they were able to provide some very compelling explanations about how much difference it made and how much people in related roles who were, in a sense, gatekeepers or impediments to progress and cooperation of an interprofessional sort came to understand, begin working together, and so on. And the external evaluation that Pyre provided to Dave and his company and the people at the national level of the VA system and so on was outstanding in terms of the results that were produced in that period of time. What that illustrates for me is that in those instances where you don't have the commitment of a local group or association or arrangement, such as Barb did for her conference, an externally funded project provides an opportunity for a level of creativity and use of evaluation and follow-up and so on that sometimes you can build on and learn a great deal about that specific instance that has implications for other similar things that you're doing. And the third and final example is that Kurt referred before to the fact that there is an international compendium of adult and continuing education, and that there's a website about that explains it in some detail, and any of you have difficulty opening up that and are interested in that or related information, just contact me, send an email, and I'll follow through and help with that as well. But one of the features of that is that people in various parts of the adult and continuing education field, including especially people in the helping professions, which are very prominent in that effort, not only in North America, but in various countries around the world, are during this calendar year putting together succinct and substantive articles ranging from 300 words to 3,000 words, so they're relatively brief, for that one volume, relatively inexpensive compendium. That's an e-volume, which means that people can access it and use it, and use hyperlinks as a way of connecting as well. And so it's like the terminology project of JSEP and SACME on steroids, because there are will be eventually between 120 and 150 of those brief articles. The important point is that people who are interested, as the people were for the terminology project, are willing to spend a little bit of time and interacting with other people who care about that particular topic, issue, example, etc., to put together an article or to help as consulting editors to review manuscripts and so on, so that they are practical and clear for people in various occupations. So in my reflections editorial for JSEP, I alluded to that as the next step, and I am pleased to report that that next step is already happening, and any of you who are interested in that, let me know, and I'd be glad to send you additional information. And if any of you are interested in preparing one of those articles or being one of the reviewers of other people's manuscripts, please let me know.
Mm-hmm. And I'm pleased to say that we have a participant standing by here, John Parbusing. Please go ahead, John.
Well, thank you. I'm really enjoying this discussion and some of the examples that Alan has given, trying to make notes actively about that. But just thinking about it, reflecting on the last 70 years of formal CME, and the most recent initiative to move to a more learner-centered approach. There are, I think of sort of 4 milestones in the history of CME that we haven't really addressed. A new looking at it from the learner's point of view. And the very first 70 years ago when we started to talk about who was the best teacher, and the educator said, well, it's the person who did the research, and so we ended up with an academic sleuth of teachers and eventually a circuit of speakers. Well, from the learner's point of view, there's good evidence that shows that the first question the learner asks is, can I make this change myself? And it's not the experts going to answer that. It's going to be a peer, someone who has already made the change. And I don't see too much of that happening when if you look at the most recent brochures that coming through our post on who is the right teacher. The next sort of milestone that I pointed out was when needs assessments came in. And first of all, they were the very primitive surveys, and then they're becoming more sophisticated, etc. Well, when I talked to physicians recently and in my recent past, I don't even mention the word needs assessment. I talk about a with me, and that is a what's in it for me. What is, and I refer to a with me score when I start to address different members of my learning community. Who is prepared to drop what they're doing and come to an education session about this? And there's an emotional involvement, which again, from the educators and teachers centered formal CME, we were not allowed to bring emotions into this. But in fact, from the learner-centered side, there's an awful lot of emotion in a what's in it for me score. So I refer to, instead of needs assessment, what's in it for me. Then we came to the next stage, was the learning environment, and the idea of taking doctors out of their workplace where they're too busy and occupied and taking them to a different place where they can learn. Well, I think the learner really who wants to embed improvement into their daily work wants that education in the workplace. And so that's again a different change. And the last sort of milestone, of which the one that I'm most interested in is we now know that learners who know each other are more likely to adopt things because they can interact with each other on a more personal and emotional basis and adopt new things like this way. Well, from the teachers and the educators' point of view, we took them away from their workplace and we put them in workshops where they don't know each other. They've come to Miami to a conference and they're just sitting in a breakout session and they don't know each other. And in fact, in many occasions, the CME provider has said we want to break up those people who are going to talk to each other because we want them to focus on the teacher. So I've just summarized what I would say for my reflections of 70 years of CME and how they could very subtly be changed from an educator-centered approach to doing things to the learner-centered approach.
Thank you very much. I can't think of a better conclusion for our hour together today than those 4 points. In terms of thinking of the best teachers, that brings me back to the notion of a mutually beneficial exchange between people who did do the research and other people who can contribute to learning activities and preparation for them and so on. And that teamwork, it seems to me, is promising. And the notion of a mutually beneficial exchange, you've illustrated in terms of your second point on needs assessment, in terms of what's in it for me, enlightened self-interest. A mutually beneficial exchange is essential for many things that we're involved in, not only staffing, but other aspects of marketing for continuing education and so on. in terms of the environment, one of the nice things about effective interactive technology is that you can be at another location, or you can deal with some of the specifics of what you'd like to have happen by giving people as learners in CME activity access to what's going on in an operating room, as some of the examples in the book I mentioned before illustrate as well. And one of the phrases that is still useful to me as I think of interacting with colleagues in some of the continuing professional development activities that I observe is the notion of friends helping friends. Very much that spirit as well. So, John, I thank you for the benediction for this sermon. We had a text sort of earlier. I've been trying to serve as a tour guide to some of this, and I thank you profusely for providing an excellent benediction. Thank you.
Very good. Well, I'm going to read one more comment, which I think echoes what you just said, Alan. I appreciate the examples described. You remind me to seek out and encourage existing relationships and known supporters to advance this movement. That is to say, the push to more effectively link research and practice. It may not be realistic to expect new recruits to be converted. There has to be something in it for them, as John highlighted, tying your comments, Alan, and John's together. And those benefits are not always obvious. And there's some solid research behind that approach of going with the willing in terms of dissemination of innovations and dissemination of, innovations. The early adopters, so to speak, who are the group that are open, who are willing, and provide you with that starting point on which you can build. So thank you, Alan. This has been really a very interesting session. As always, you bring a tremendous wealth of knowledge and experience, and I also enjoyed hearing the examples that you and our participants as well have described. So I thank you and to everyone who took part. And with that, I will hand it over to Mila for a final comment.
Thank you so much. And again, I thank you both, Alan, John, Dawn, everybody who participated. This was truly, I think, mutually beneficial exchange, and hopefully we'll continue to carry it on. And I wanted to remind everybody that we do record these sessions. I can see now that there is a cadre of folks who are tuning in as to most of our virtual journal club sessions, and it would be really nice to see the discussions, at least some of them, carry on in the other virtual environment, which is the discussion area. So reminding you all that we are recording it. You can go back and listen to the sessions, look at the slides where we have them. All 10 of these sessions are now going to be posted at the SACME Virtual Journal Club section, and with topics and materials, with the Journal Club calendar, guidelines, discussion area that I invite you again to contribute to, and as I said, archive sessions. I do hope that I will see most of you at the Congress. As you know, Congress is coming up, the World Congress on CPD. We are very excited about that, and decided to hold a live session of the Journal Club, SACME Journal Club, that will be open to all the members of the community, all the participants of the Congress, and this will be happening on Saturday, March 19th in the morning, 8:45 in San Diego. And the topic, so Barbara Barnes and I will be facilitating the topic on professional identity formation. As you know, this has been a hot topic recently in the literature, and we want to look at it from the perspective of the role of CPD. What can we play? What kind of a role can we play there? And look at it in a larger context of what does that mean, not just for professional identity of physicians, which is the topic in the literature, but also extrapolate that to our field overall as professionals and even the society that we belong to. So with that, I want to thank you all again and invite you to, as you think of topics, you come across interesting journal articles, that you reach out to one of us, Kurt, Barbara, and I, and just volunteer to contribute. We'd love to have you hold one of these sessions or moderate. Thank you very much.
I look forward to seeing many of you in San Diego.